This recorded lecture will be going over Chapter 29, Promoting Urinary Elimination in the Fundamentals textbook. This will be a review over these next few slides from our structure and function portion of the program. So the structures involved in urinary elimination are, of course, our kidneys. They are two bean-shaped organs. They are 2.5 inches wide, 5 inches long, and 1 inch thick. They are located at the level of L1 on each side of the spine. Each of our kidney contains approximately 1 million nephrons. Those are the working units of the kidney. And each nephron is a glomerulus, which consists of a cluster of capillaries surrounded by a Bowman's capsule and a system of tubules. And we know that that is how our kidneys will absorb and transfer nutrients from the capillaries. The ureters are hollow tubes. They are about 10 to 12 inches long in the adult, and they connect the kidney to the bladder. The bladder is hollow. It's a very muscular organ located in the lower pelvis. The urethra is a tube attached to the base of the bladder. It extends to the outside of the body. The internal and external urinary sphincters will control the flow of urine out of the body. And this picture can be seen on page 551. As well as this picture of the male urethra on page 551. The kidneys filter blood through the nephrons, and metabolic waste and excess water are then extracted. They regulate electrolytes in the body by excreting excess amount and assisting in acid-base balance by retaining or excreting hydrogen ions and bicarbonate ions. Our kidneys manufacture about 1 to 1.5 liters of urine on average in about 24 hours. Urine output will be related to the amount of fluid intake, and this can vary considerably. The ureters will carry urine from the kidneys to the bladder, and the bladder will then store the urine and send a signal to the spinal cord when it is full and ready to empty. The bladder can hold 1,000 to 1,800 milliliters of urine. Our average urine output is 1,000 to 1,500 milliliters per day. The urethra will carry the urine from the bladder to the outside of our body, and the urinary meatus is the exit point for urination. The internal sphincter will relax in response to micturition, or urination reflex. We have voluntary contraction of the external sphincter, which will stop the expulsion of urine. Factors that will interfere with our urinary elimination include a loss of the kidney's ability to manufacture urine, also known as kidney failure. This can result in anuria, which is the absence of urine. Decreased kidney perfusion can lead to kidney damage. Blockage of the ureters will prevent urine from traveling to the bladder. This blockage can occur due to presence of stones in the ureters, possibly pressure from a tumor in the abdominal cavity, or trauma to the lower abdomen. Disruption of the bladder by tumor or trauma, pressure on the urethra from an enlarged prostate. Infection in any part of the urinary system will cause inflammation and can alter the flow of urine. Neurologic damage to the nerves that control our internal and external sphincters of the muscular wall of the bladder, and prostate surgery can also damage the internal urinary sphincter and can cause permanent or temporary incontinence in our male patients. With aging, of course, there is a decrease in the number of functioning nephrons, and resulting in that is a reduction in the rate of renal filtration with aging. Because of this, we need to be more careful with the medications that we're giving, because minor body stresses can cause a decrease in kidney function. The bladder muscle tone will decrease as we age, its capacity will lessen, and this can cause nocturia, which is urinating throughout the night. Incontinence is not necessarily a normal part of aging, and it should be addressed with a primary care doctor. Decreased bladder and muscle tone can cause incomplete bladder emptying and result in residual urine, which is urine left in the bladder after urination. This residual urine can become stagnant and will then predispose the person to an infection. Lower estrogen levels in women will also result in tissue atrophy in the urethra, the vagina, and the bladder, which can also predispose our female patients to infection and incontinence. The frequency of urination will vary. There should be at least an hourly urine output of 30 mLs. This will reflect adequate kidney perfusion. People usually have the urge to void upon awakening in the morning, after each meal, at bedtime, and after drinking any extra fluids. Urinary elimination is affected by neurologic and muscle development, alterations in spinal cord integrity, the volume of fluid intake, the amount of fluid lost by perspiration, vomiting, or diarrhea, and the amount of antidiuretic hormone, or ADH, that is secreted by the pituitary gland. Most people will typically need privacy for urination to happen freely. Urine should normally be a shade of yellow, but the color can darken when our urine is more concentrated. Urine should be transparent or only slightly cloudy. Cloudy urine can contain bacteria or large amounts of protein. Normal urine should smell faintly like ammonia. If the odor is particularly foul, an infection could be present. If the odor is fruity, ketones are present. Specific gravity is the thinness or thickness of the urine. This can be measured with a urinometer and is also assessed within a urinalysis. The normal range of specific gravity should be 1.010 to 1.030. Conditions such as dehydration and fluid excess can extend the range slightly in either direction. The pH of normal urine is slightly acidic and will range from 5.5 to 7.0. On page 553 in the Health Promotion green box, be sure to look at the tips on how to prevent recurrent cystitis, especially for the female patient, avoiding wearing tight clothing and nylon pantyhose that will cause continual perineal moisture. Instead, wear cotton underwear. Also on page 553, we can see box 29.1, alterations in urinary elimination patterns. We know that anuria is present when less than 100 mL of urine is excreted within a 24-hour period. Dysuria is painful or difficult urination. This can occur with inflammation in the bladder or urethra. Incontinence is an involuntary release of urine. This can be caused with a variety of pathologic conditions. Nocturia occurs when the person needs to get up and urinate throughout the night, usually more than once or twice. Oliguria is a decreased amount of urine output and typically occurs when the urine output falls below 400 mL over a 24-hour period. Polyuria is excessive urination, and this will occur when large amounts of urine are voided, typically an output greater than 1,500 mL over a 24-hour period. Alterations in urinary elimination patterns can occur. A common UTI is cystitis. This is inflammation of the bladder. Cystitis can be caused by irritation of highly concentrated urine, pathogenic bacteria, injury, or installation. This is putting a solution of an irritating substance within the body. Symptoms of cystitis are frequency, urgency, dysuria, burning, suprapubic pain or tenderness, foul-smelling urine, and a slight temperature elevation. Be sure to see the lifespan considerations on page 553 in the green box. Your older adult patient may develop an infection and may not manifest a fever. In fact, their temperature could be slightly lower than normal. Subtle changes in mental status may be the first symptom of an infection, so be sure to monitor the older adult closely for changes in alertness and orientation. Disorientation and confusion can often be one of the first signs of a urinary infection in the older adult patient. Urine specimen collection can be done in many different ways. A normal voided specimen, a midstream or clean catch specimen, collecting a specimen from an indwelling catheter, a sterile catheterized specimen, a 24-hour specimen, or a strained specimen. And we'll go over those in the next few sections. Obtain a history of the patient's usual urinary elimination pattern. Ask them about any incidences of incontinence. Assess the patient's mobility to determine whether or not it's safe to allow them to ambulate to the bathroom without assistance. Each patient should void at least every 8 hours unless they have an indwelling catheter in place. If voided amounts are small and their intake is normal, you should gently palpate the bladder to see if it's distended. To do this, feel with the palm of your hand for a bulge that would indicate a full bladder above the symphysis pubis. On page 554 in box 29.2, we can see some abnormalities commonly found in a urinalysis. Glycosuria will be glucose in the urine. Proteinuria is protein in the urine. Hematuria is blood in the urine. Pyuria is a purulent exudate in the urine. This would be pus. Ketonuria is when you find ketones in the urine. CAS can occur in increased numbers with the presence of bacteria or protein. This can sometimes indicate urinary stones or kidney disease. Red blood cells in the urine that are greater than 0 to 2 cells can indicate a stone, tumor, glomerular disorder, cystitis, or a bleeding disorder. White blood cells in the urine can be indicative of an infectious or inflammatory process. And bilirubin in the urine will suggest liver disease or obstruction of the bile duct. There are many different catheter types as well as many different specimen types that we can collect from urinary devices. A voided specimen for collection or a routine specimen would be utilized for inspection of the urine. If the specimen is to go to the laboratory, it would be important to transfer it in the specimen container, then label it properly and send it to the lab within 5 to 10 minutes of collection. Urine that stands for 15 minutes or more will change its characteristics, and the urinalysis will then not be accurate. Dipstick tests containing chemical reagents are routinely performed in medical offices and outpatient clinics. These can test for a variety of components, including glucose, ketones, protein, blood, specific gravity, pH, nitrate, bilirubin, and leukocytes. Exact timing for checking each of the components is essential for accuracy of the result. A midstream or clean catch urine specimen is a procedure used to obtain a specimen that is used for a culture and sensitivity test whenever a UTI is suspected. A specimen from an indwelling catheter is a specimen that can be obtained from a self-sealing port of an indwelling catheter system. You can see a great picture of this on page 555 in figure 29.5. A sterile catheterized specimen can be collected when a sterile specimen is ordered and the patient does not have an indwelling catheter in place. This patient should be catheterized with a straight catheter that does not have a balloon, and this can be attached to a small collection bag, or the urine can be collected by placing the distal end of the catheter into a sterile specimen container. For a 24-hour urine specimen, you would collect all the urine voided within a 24-hour period. It needs to be collected in designated containers and stored on ice if necessary. A sign should always be posted over the bed and over the toilet, indicating that all of the urine needs to be saved. The patient's bladder should be emptied at the beginning and at the conclusion of the test. The patient empties the bladder just before beginning the collection, and then that urine is thrown away. At the ending time, the patient voids again, and then that urine is added to the collection container. A urinary collection bag is a device used to obtain a urine specimen from an infant or toddler. The skin is cleaned, and then the device is attached to the skin by an adhesive backing, which is placed so that it surrounds the genitalia. This type of collection device can also allow bacteria to get into the specimen from the surrounding skin. A strained specimen can be utilized if a patient is suspecting of having a urinary stone. In this situation, all urine is strained when it is voided. Usually a fine sieve is used. If a stone is found, it needs to be saved and then sent to the laboratory for further analysis. When planning, if a patient has been prone to UTIs, you should plan to increase their fluids unless it is contraindicated, and reinforce any patient education regarding ways to prevent any further UTIs. When planning care for your patient, remember to always be culturally sensitive in helping your patient meet their toilet needs. Discharge planning should include ensuring that arrangements are made before the patient goes home for any devices like grab bars by the toilet, a commode chair, or a raised toilet seat. Always keep in mind that urinary elimination is usually an independent function, and most people will be embarrassed about needing assistance. Assisting patients with urinary elimination is a basic nursing function. Patients who can ambulate can be assisted to the bathroom to use the toilet. Others might use a commode chair for bowel or bladder elimination. This is usually placed at the bedside or a short distance away. The patient would then be transferred from the bed to the commode and then back again after they are finished voiding. The receptacle would be emptied after each use. Patients who have difficulty with hip flexion or have had a hip replacement may need to use a raised toilet seat. This is a frame device that fits over the toilet bowl and has a toilet seat attached to it at a higher point than is usual for a toilet. A patient who is too weak to walk to the bathroom might be able to use a bedside commode safely. This could be an appropriate alternative for a weak patient who can't necessarily walk all the way to the bathroom, but they can successfully transfer to a bedside commode. Patients on bed rest will be provided with a bedpan for elimination. The bedpan should be covered if it must be carried outside of the patient's room. Use a paper towel or a small hand towel. A fracture pan is a bedpan that can be used when patients are unable to sit on a regular size bedpan. The fracture pan is smaller in surface area and height. This is used for patients with musculoskeletal problems. The flat end with the wide rim should be placed under the patient by separating their legs and slipping the pan underneath the buttocks. For the ambulatory patient who needs urine output recorded, place a plastic hat device towards the front of the toilet bowl between the bowl and the seat. After each voiding, you should empty, rinse, and replace the container so it's ready for the next voiding. When a male patient requires assistance to use a urinal, the nurse will assist the patient to stand beside the bed if that is possible. A patient who is confined to bed can use a urinal in any one of these 4 positions: lying supine, lying on either their right or left side, or lying in a Fowler position. Always be certain that after the patient uses their urinal that the penis is dry. Patients often have difficulty urinating after surgery and anesthesia, childbirth, or any other trauma to the perineum. All efforts should be made to help the patient void naturally before resorting to catheterization. On page 561, we can see some methods of helping patient initiate the voiding reflex. Some of these techniques include running water in a nearby sink so that the patient hears the sound. Have the patient deep breathe, relax, and visualize a peaceful place with a bubbling brook. I always tell my patients to envision themselves stepping into a hot tub or stepping into a pool. Help the male patient stand on the side of the bed if appropriate. Have the female patient blow through a straw in a glass of water, causing bubbling. Measure several cups of warm water and then pour the water over the perineum while the patient attempts the void. With an order, gently but firmly use a Creed maneuver over the bladder. This is a massage, starting from the top of the bladder to the bottom. Obtain an order for a sitz bath and have the patient sit in warm water. Encourage them to void while in the bath and then clean the perineum afterwards. If a patient cannot empty their bladder naturally for a period lasting longer than 8 hours, a bladder scan should be performed using an ultrasound machine that is designed for that specific purpose. A bladder scan can also disclose the amount of residual urine in the bladder that is left after voiding. This will be able to tell your primary care provider whether the bladder is emptying sufficiently or not. This is also known as a post-void scan. Some additional reasons for catheterization would include preparing a patient for a surgical procedure or an obstetric delivery, keeping the genitalia and perineum clean after any obstetric or surgical procedures, dilating a urethral stricture, splinting the urethra following surgery, measuring the amount of residual urine in the bladder, monitoring hourly urine output or obtaining exact measurements of total output, performing any irrigation or installation and drainage of chemotherapeutic solutions into the bladder, and assisting with the retoning of the bladder muscle after surgery on the bladder. We have different types of urinary catheters that are shown on page 563 and explained on page 562. Catheters will come in several sizes and shapes, and they are either rubber or plastic. Some can be Teflon coated. They're sized using the French system, with the average size used for an adult woman being 14 to 16 French, and for an adult man being 18 to 20 French. A straight catheter, also known as the Robinson, is used to relieve retention when a patient is temporarily unable to void or to obtain a sterile specimen. A Foley or retention catheter is the most common form of indwelling catheter, and it can remain in the bladder for an extended period of time. A Coude catheter, which is a variation of the Robinson catheter, is curved and has a rounded or bulbous tip that is easier to insert into the male urethra when the prostate is enlarged. The Alcock catheter is used for continuous bladder irrigation. This would be following a prostate or bladder surgery. It is a Foley-type catheter, but it has two drainage eyes. We are familiar with the condom catheter that consists of a condom with a tube attached to the distal end and then attached to a drainage bag. This can be used to provide continuous urine drainage for a male patient in a non-invasive manner. Sterile equipment and strict aseptic technique must be used to catheterize a patient. Any break in sterile technique causing contamination needs to be corrected before continuing on with the procedure. Catheter kits can be used for males or females. When inserting a catheter, you should gently insert until you see the urine flow, and then insert 1 to 2 more inches. On pages 563 through pages 565, you can see the steps in skill 29.2 for applying a condom catheter. And then you can also see on 565, catheterizing a female patient. And on page 568, you can see the catheterization of the male patient. It's always a good idea to identify your urethral meatus in the female patient before beginning your Foley insertion or catheter insertion procedure. When the patient is in the dorsal recumbent position and draped, put on your examination gloves, use adequate lighting, and then spray the labia minora to reveal the inner anatomy. The urethral meatus is usually slightly above the vaginal opening and will often look like a dimple or a fold in the mucous membrane. After insertion, the catheter will be secured to the thigh of the female, preferably the inner thigh, and to the top of the thigh or abdomen of the male. Allow a little slack in the catheter before securing it to the skin so that there is not constant tension on the internal sphincter by the balloon. The perineum is cleaned during the daily bath, and the external portion of the catheter is washed at the time that it is soiled. Nurses have a very serious role in preventing catheter-associated urinary tract infections. Nurses need to be aware that CAUTIs result in approximately 30% of hospital-acquired infections every year. Medicare and Medicaid will no longer reimburse for this complication because a CAUTI is viewed as an indicator of poor care. Nursing interventions such as maintaining basic infection control procedures, including hand washing, using bladder ultrasounds, and placing condom catheters or other alternatives, have been proven to reduce the number of UTIs. Another UTI preventing intervention is the use of a checklist, which will include the reason for the catheter and the number of days the catheter has been in place. See the CUSIN considerations on page 572, automatic stop orders. Removal of an indwelling catheter. Evidence-based practice indicates that automatic stop orders will reduce the incidence of CAUTIs. If a facility does not use an automatic stop order system, it is then the nurse's responsibility to obtain an order for removal as needed. The patient should be kept on intake and output recording for 12 to 24 hours after their catheter removal to ensure that the bladder is draining adequately. A suprapubic catheter can be used for urine drainage following a gynecologic and bladder surgery. This would be inserted through the abdominal wall by a surgeon. Intermittent self-catheterization can be used for patients who regularly experience incontinence or urinary retention. These patients need to be taught and encouraged to participate in their own care. On page 573 in the blue patient education box, we can see some tips for self-catheterization. It would be important to focus on performing hand hygiene, making sure to cleanse the urinary meatus with a towelette or soapy washcloth, then rinse with a wet washcloth and pat dry. If the patient is a female, hold the inner labia open and stroke down and back to prevent fecal contamination of the meatus. For the female, locate the meatus by touch. Place the index finger of your non-dominant hand on the clitoris. Place the third and fourth fingers at the vaginal opening and locate the meatus between the index and third fingers. Separate the labia. For the male, lift the penis to a 60 to 90 degree angle to straighten the urethra before inserting the catheter. With the drainage end over a basin or the toilet, insert the catheter into the meatus. For the female, direct the angle toward the umbilicus. Twist the catheter as you advance it in. If resistance is met, take a deep breath while trying to advance the catheter. Hold the catheter in place until all the urine stops draining. Then pinch and withdraw the catheter slowly. Most catheters are usually designed for single use. You should dispose of the catheter in the appropriate receptacle. Bladder irrigation or installation is typically performed on patients with indwelling catheters. We do this to wash out any residual urine or sediment from the bladder, to remove any clots and stop the oozing of blood after surgery, to soothe irritated bladder tissues and promote healing, to ensure that the lumen of the indwelling catheter is open and draining, and also to instill any medication into the bladder. Continuous irrigation should be performed after prostate or bladder surgery with a three-way indwelling Foley system where the irrigation solution is hooked up to the irrigation port of the catheter. Generally, you would set the irrigation solution to flow just fast enough to prevent any clots from forming in the bladder. The irrigation solution is changed every 24 hours, and all irrigation fluid is subtracted from the amount of output. Strict asepsis is important to be maintained, and take special care not to contaminate the end of the drainage tubing or the end of the catheter. There are several different types of incontinence: urgency, stress, overflow, functional, mixed, or nocturnal enuresis or bedwetting. The incontinent patient will suffer a body image disturbance. There is a risk of skin breakdown from moisture and waste products in the urine, as well as the worry over being wet and smelly of urine. There is also the risk of infection because urine is a medium for bacterial growth. Urinary incontinence can be temporary or permanent. For some patients, better and quicker assistance to the toilet can resolve this problem. For others, continence training may be beneficial. On page 578 in the patient education box, you can see some pelvic muscle or Kegel exercises that can be used to correct incontinence. Teach your patient to concentrate on stopping the flow of urine when they're voiding by tightening their pelvic muscles. If you can't identify the correct muscles in this way, instead place a finger inside your vagina if female, or rectum, and try to squeeze around your finger. These are the same muscles that you use to keep from expelling gas or a bowel movement. If you are contracting your abdominal muscles, you're doing the exercise incorrectly, and do not hold your breath while contracting and holding. Absorbent pads are similar to sanitary napkins, and these can also be used for women or men. Urinary diversion is necessary when the bladder needs to be removed or bypassed for some reason. When the ureter exits on the abdominal wall, discharging urine will go through the opening. That's called a urostomy. Collection of the draining urine and care of the skin around the urostomy are nursing responsibilities. Urine contains ammonia. This is irritating to the skin, and a skin barrier should be applied before attaching the collection appliance. Record the intake and output and compare any data from day to day to indicate whether or not fluid intake and output are sufficient for your patient. Of course, obtain feedback for all patient education that is performed. If a patient has problems with urinary elimination, you need to document the number of voidings per day, the amount of urine output, and the appearance of the urine. When a patient is catheterized, note the appearance of the urine returned from the catheter and any problems that you encountered during the procedure. A description of the urine should be documented at least once per shift, and whenever a patient has an indwelling catheter. When documenting, always include any signs of infection or any resolution of infection. For the incontinent patient, the assessment of the perineal skin should be documented at least once per shift. If bladder irrigation or installation is performed, document the amount of solution instilled, whether aseptic technique was maintained, the time the fluid remained in the bladder, the amount and description of the outflow, and any problems encountered during the procedure.